hindi lahat magkakaroon ng infection kahit na lahat na-expose.
Kapag ang virus hindi pumasok sa loob ng host, hindi siya makakapag-mutate sa labas.
Obligate intracellular parasite.
Mutation. But wearing a mask is mandatory. People have clean hands, but there is a ban on shaking hands. Your friend has time to sit together, but they cannot sit together.
Good evening, everyone. Welcome po ulit sa ating PSD Select discussion. Pangatlong linggo na po natin ito to talk about diabetes and COVID. So, before we begin, we all put ourselves in the presence of God and let us pray. For me, I will start my prayer with Bismillahirrahmanirrahim. So let us all begin to pray. So may our God bless our activity, our speakers, and participants. Amen. So, again, welcome to our third week of the PSD Select. And it is my pleasure to be your host for this evening. Let us begin by giving you our reminders. No? We encourage everyone, dapat po tayo mag-attend nitong PSD Select because this will be our requirement for to maintain your status of good standing. Parang siya po yung kapalit ng ating regular annual workshop. So, please join us on every week if you can kasi ito po yung kailangan para mabuo natin yung ating requirement for good standing. So, those of you whose name in the chat box doesn't appear as your complete name, sumulat na lang po kayo sa chat box at ilagay, I am Fatma Chu, I am present. Okay? And before we turn you over to our to our moderator, we would like to give you some good news. Meron po kaming mga napili na bibigyan natin ng mga premyo. This is based on their active participation during the past PSD Select. So, yung mga nandito ang pangalan po, you will be receiving our prizes. We will be mailing it to you. Ang ipapamigay po natin this week is, tama ba ako? We will be giving away, ayan, yung ating PPE at yung ating alcohol dispenser. So, 37 po ang magiging recipient niyan. Hindi po sila sabay na pareho Some will receive a PPE and some will receive an alcohol dispenser. So, ipamigay po muna natin yung alcohol dispenser sa first 27. Ang first 27 na lang po yung alcohol dispenser. So, yung top 27, pabalik po yung mga names. The following will receive alcohol dispenser. So, Ayan po, si Dr. Lea Kailo, Dr. Toledo, Dr. Pasaporte, Dr. Santos, Elvis, Pabua, Fajardo, Abdurrahman,
Congratulations.
Dr. Rafael Cruz. Andyan po ba kayo? Dr. Lou Gonzales, si Dr. Nines. Ito po sila yung mga nagtanong or basta in any way nakita namin yung laging nandiyan dyan, nag-attend, nagsulat ng kanilang mga opinion or mga bumate, basta nakita namin kayo dun sa chat group. Itong mga to po ang nabigyan. Okay? Dr. Rimatan, Dr. Caridad Hipolito, Dr. Alvin Andaya, Dr. Eden Karingal, Dr. Tony Chua, Dr. si Kuya Rino Sobrepeña, baka i-donate na lang yan. Dr. Grace Ronan, Dr. Caridad Hipolito, Dr. Gloria Craig, Dr. Elenita Santos, Dr. Maria Agnes Soriano, Dr. Liza Marie Pastan, Dr. Lorna de la Vega Torio, Dr. Frances Soliven Quebec, Dr. Cynthia Sanchez, si Mama Grace de los Santos, and Dr. Ben Sinor. So congratulations po sa inyong lahat. You will be receiving an alcohol dispenser or a PPE. So Lynn, our secretariat, will get in touch with you. Congratulations po again. So again, we would like to tell you all that this activity is a CME grant from our friend Getz, and we have with us one of their somebody from Getz to talk about an update, maybe something from their company, or to thank us for partnering with us. So let us all welcome si Ma'am Rose.
Hi, Doktora. Good evening po.
I'm sorry, si Ma'am Rose, no?
Yes po, Doktora.
Yes,
Thank you, Doktora
I forgot
Fatma.
your full name.
It's okay po, Doktora. Thank you very much. Again, thank you po again. Good evening, doctors. My name is Rosa Andrasas from the Diabetes Care Team of Getz Pharma. And allow me to present to you our brand of insulin glargine, Basagine, the ease of base for insulin therapy. Again, because it is affordable, combines flexibly, and evidence-based. And doctor, why Basagine? Basagine because of its control in HbA1c, Filipino practicality, and quality in manufacturing facility. And why Basagine again, doctor? Basagine, just like our Instaget, doctor, is not only affordable but also world-class. World-class as Getz Pharma's manufacturing facility and control laboratory is pre-qualified and approved by the World Health Organization Geneva and Pharmaceutical Inspection Cooperation Scheme. Basagine comes in 100 IU, 3 ml vial preparation, and is the only insulin in IPVC tray for vial protection. Again, doctors, our insulin glargine, Basagine, 3 ml vial, the practical choice for insulin initiation. Again, Doctora, thank you very much.
Okay, thank you, Ma'am Rose. So let us now proceed with our main activity for tonight. I would like to welcome our moderator for this evening. Let us all say hello to Dr. Marcy Cruz. Hello, Mars.
Nakamute yata si Ate Marcy.
Oo. So, habang nakamute si Ate Mars, let me...
okay, yan na.
Ayan na.
Okay. So, we have our third series, the PSD Select. Tonight's topic, we have what defenses against viruses do we have? And for clinical, we have the treatment of diabetes in patients with COVID-19. So, let's introduce our first speaker. Our speaker is our kuya in ISDFI, and to me, a kuya from my residency training. up to the present. I called him up every time I have a difficult case. I handle difficult cases. Without further ado, presenting to you the president of the Philippine Society of Diabetologists, Dr. Elwin Fernando. Kuya?
Salamat, ate. Mag-ano na ako, mag-share na ako ng slide, ha. This, ayan, teka lang, ha. Screen share. Yun. Palagay ko, nakikita ko na eh. Nakikita nyo na rin siguro, no? So, kwentuhan ulit tayo, ha? At kamukha nung pinagsisimulan natin, itong series na to, meron tayong isang lecture on basic knowledge on current issues. And then after that, kwentuhan tayo ng something that is clinical. And when we talk about basic, yung talagang basic lang. Kaya nag-enjoy ako sa kwentuhan kasi basic eh. Ngayon, before I go on, magpapasalamat ako sa Gets Pharma for sponsoring us tonight, no? Ay, mahirap kumuha ng sponsor. Alam niyo kung bakit? Kasi tayo ang namimili ng topics at saka tayo rin ang nagkukwentuhan. Kaya malaking bagay yung tulong na binibigay sa atin ng ating sponsor. Kaya again, salamat Gets for being with us and for seeing the value of what we are doing. Yung susunod na slide ko, no? Siguro nakita nyo na sa inyong mga internet, no? Kahapon lang lumabas yan eh. Pero kung nakikinig kayo sa kwentuhan natin, maintindihan nyo kung ano sinasabi niyan. Pero nyo, med page yan. Pinakita nila sa internet. At kung nakikita nyo yung aking pointer, wala. Saan yung pointer ko? Ayun, no? Sabi dito, no? Scientists analyzed a large collection of genetic sequences of SARS-CoV-2 and found that the virus has been mutating and possibly become more contagious according to a paper released before peer review. Ngayon, napag-usapan natin dati pa na ang lahat ng virus nag-mutate yan all that time. Kaya kung scientists yan, hindi nyo sasabihin na they just found out that the virus has been mutating. Alam niya na nag-mutate all the time. Pagkatapos sasabihin, possibly become more contagious, alam natin na in the same epidemic, ang chances are it will become less and less virulent para maging para tumagal ang buhay ng virus at saka ng host. Pero isa pang yung term na contagious, medyo ang hirap din i-explain na contagious, yung nakakahawa siya. No? Kaya ibig niya sabihin, hindi na yung ACE2 receptor ang yung mutation niya o naging dalawa na ang possible na functional receptor niya. Walang virus na kung alam na dalawang functional receptor. Isa lang yan talaga eh. At saka yung pagiging contagious, kadalasan it's because of the habits of the host. Ayaw mag-mask ng lahat ng tao eh. Kaya kumakalat. Pero yung huling sinabi dito na medyo nakaka-question is released before peer review. Hindi ginagawa ng mga medical journals yan. It's either after peer review, they reject or they accept a literature. Pero ito, na-release before peer review, talagang, ito mga Washington Post, talagang mga journalist talaga eh. Mahilig sila magbigay ng mga ganyan eh, na hindi pa sigurado. No? And number 2, na siguro nag-strike sa akin dito sa nilabas nila, yung sinasabi dito na the FDA authorized AssureText Rapid SARS-CoV-2 antibody test for point-of-care use. Antibody test for point-of-care use. Yung gagawa niyan. Yung antibody test para malaman mo kung nagkaroon na siya o hindi pa nagkaroon ng COVID-19 or infection. No? Pero kung malaman mo kung gagamutin mo yung individual o hindi, kailangan mo antigen test, hindi antibody test. Kaya kung minsan, kung magiging critical kayo, maintindihan nyo yung mga sinasabi dyan sa pinapost. Pero ano yan ha? Med page yan. O, ngayon, at least you will now be critical also with what you are reading. No? Ayan. Hingi ako ng 30 minutes less than 30 minutes para sagutin natin yung bagong tanong ni Nadia Betis. No? Kwentuhan style pa rin. Ha? Dati, first time, what is SARS-CoV-2? Ang sinagot natin. Sumunod, ano yung life cycle ng virus na yan? Ngayon, ang pag-usapan natin host defenses. Kasi karamihan tayo, ang feeling natin sitting duck na lang tayo sa mga viruses eh. Wala tayong panlaban sa viruses, no? Ganyan din siguro ang feeling ng Archbishop na sinabi, basta na hindi na daw kinakailangan mag-face mask at ayaw daw ng Panginoon na lumalatayo tayo sa kanya. Ito, no? Dito sa 30 minutes na to, 20 or 30 minutes na to, sana maintindihan nyo, no, na di sa mga nangyayari na to, hindi naman tayo ilalayo sa Panginoon eh. Pinapakita na nga ng science na napakalapit sa atin ng Panginoon. Nung creator natin, napakalapit sa atin at iisa-isahin natin yan. Yung kaya lang natin dito sa 20 or 30 minutes. Doon nga sa sa book na Deuteronomy. Meron din yan sa Deuteronomy din sa sa book ng mga Hudyo. Meron din sa Quran ng Deuteronomy. Sabi diyan, be strong and courageous. Do not be afraid or terrified because of them, for the Lord your God goes with you. Laging nakasama ang Panginoon. Nandiyan yan. Makikita nyo, levels of host defenses. Maraming levels yan. Ang isang level is physical barriers. Ang physical barriers level, non-specific yan. Kahit anong virus, bacteria, fungi, toxin, yan yung mga anatomical barriers against these invaders. They are continuous. Nandyan siya lagi. Yan yung ating skin, yung mga peklat, saliva, mucus, tears, stomach, defensins, natural microbial flora. Pag-usapan natin ng konti mamaya yan. Pero nevertheless, pag masyadong marami yung virus, yung iba nakakalusot dyan sa physical barriers at umaabot doon sa second barrier na tinatawag na intrinsic defense. Yung intrinsic defense, usually, walang kinalaman gaano sa immune system yan. Pero lagi siyang present. Non-specific yan. Immediate ang kanyang response because it is always there. Yung intrinsic immunity, yan yung mga interferons, autophagy, apoptosis. Sa ibang species may tinatawag na microRNAs at saka CRISPRs. Huwag nyo may memoryahin yung mga yan. Pero pag-usapan natin in a way na overview na natin mamaya. No? Kita nyo, binigyan tayo ni Lord ng physical barriers. Ibig sabihin, lagi siyang may padala sa atin against parasites. Pagkatapos, hindi lang yun. Binigyan din tayo ng intrinsic defense. No? Pero yung mga virus, magagaling mag-shortcut o mag-overtake eh. Pwedeng makalusot pa rin yan pag marami yan. Meron pa rin susunod na defense dyan. Ang tinatawag sa susunod na defense ay innate immunity or innate defense. Yung innate immunity, meron na yung konting participation ng immune system. Kaya itong innate intrinsic immunity, may konting, at saka yung tinatawag na susunod na barrier, may konting ma-overlap yan. Yung innate immunity, yung defense na yan, no, it is non-specific. Yung tatlong barriers na yan, non-specific yan. Whether bacteria, whether virus, toxin, non-specific sila. Yung intrinsic, napakabilis dumating. Pero yung innate immunity, it takes a few minutes. Like for example, no, pag may pumasok na virus, nandyan lagi yung physical barriers, lagi nandyan yan. Pagkatapos nung nakalusot sa physical barriers, nandyan yung intrinsic immunity, lagi pa rin nandyan yan. Pero pag nakalusot pa rin siya, ma-activate na yun, yung innate immunity after a few minutes or a few hours. Yan na yun, yung mga natural killer cells, yung complement system, cascade, antigen-presenting cells, mga neutrophils, at saka yung production of cytokines. They come after a few minutes to a few hours. Different levels of protection. Always with us yung mga yan. Kaya kung sasabihin, lumalayo sa atin ng Panginoon. Kahit saan tayo pumunta, meron siyang semblance ng binibigay niya sa atin. No? Ngayon, pwede pa rin makalusot yan ng virus. Galing yung virus, ano? Yan ay produkto ng matagal na pag-mutate. Kaya kahit pa paano, nalulusutan niya one barrier after another through time. Pero pag nakalusot siya sa innate immunity, merong last barrier na tinatawag na adaptive immunity. Konti lang pag-usapan natin sa adaptive immunity ngayong gabi. Siguro pag-usapan natin yan more in detail pag ang pinag-usapan natin vaccines. Kasi mga vaccines, nakatuon kadalasan yan sa adaptive immunity. Adaptive immunity is something that the immune system learns. Kaya nga sa vaccine, di ba? Nagbibigay ka ng vaccine para malaman niya na merong danger pag dumating yung ganong klaseng antigen. This takes hours to days, sometimes weeks or months, yung adaptive immunity. At dyan ang nagpa-participate yung T lymphocytes, yung B lymphocytes. Nakatira yan sa iba't ibang places, nakatago sa iba't ibang parte ng ating katawan. Ngayon, pagkas yung mga bata ang pag-uusapan, usually, very, very active yung non-specific defenses nila. Yung mga bata, mga teenagers, very active yung kanilang yung kanilang mga barriers sa intrinsic, innate. Pero through time, dahil sa dumadating yung exposure sa ibang klaseng bacteria at enzymes, unti-unting nagde-develop yung adaptive immunity. Kaya pagka-adult na tayo, matanda na, ang talagang best level natin is adaptive immunity kasi through time, nakita na natin lahat ng mga antigens, lahat ng mga viruses. Hopefully, nakita na natin at natutuhanan ng ating immune system. In such a way, no, pagka tayo ay unhealthy, yung lahat ng barriers na yan, nagwi-weaken. Whether physical barriers, intrinsic, innate, lahat yan nagwi-weaken when we are not healthy. Eh, siguro yung mga smokers, nababawasan yan. Yung mucus, yung ciliation, nawawala yan sa respiratory tract, pagka-smoker. Kaya sa diabetes, naapektuhan din yan. Yung glycation, yung production of radical oxygen species. In hypertension, nababawasan din siya. Obesity, which is a chronic inflammatory state, naapektuhan din yung intrinsic, innate, and adaptive immunity to a point. Kaya, pagka merong comorbidities, mas severe ang nakikita pag nagkaroon ng infection. Palagay ko, hindi lang SARS-CoV-2 viral infection or COVID-19. Lahat halos infection. But at the same time, makikita rin at dapat ma-realize natin na with these kinds of defenses, hindi tayo pinabayaan ni Lord ng Panginoon. Meron siyang pabaon sa atin na hindi natin dapat kalimutan. Nilalapit niya tayo sa Kanya. Hindi nilalayo. Kasi ang feeling ni Father, dahil sa alam natin itong gantong klaseng science, nilalayo natin yung mga tao sa Panginoon. Hindi ganun . Kailangan maintindihan natin yan para alam natin kung paano tayo magre-respond. Lalong-lalo na sa mga pasyente nating may diabetes. Very importantly, glycemia, control of blood sugar affects all this. Kaya importante pinag-uusapan natin yan. Ngayon, isa-isahin natin itong anatomical and chemical barriers, pero very briefly lang. Yung mucus, phlegma. Importante pala yan. No? Kasi Yung phlegm, no, pagka sinisikret yan, meron din yung immunoglobulins. Ang tawag dyan, immunoglobulin A. IgA ang nasa mucus. In fact, there are certain kinds of vaccines, no, na talagang sa mucus nila dinideliver, inhalational, no, para mag-produce ng maraming IgA against these specific viruses. Saliva is also a chemical barrier. Mga bata tayo, pinaglalaroan natin laway, no? Pero it's a form of chemical barrier or pwedeng anatomical din, no? Pagka napunta sa laway yung virus at na-spit natin yan, no? Matatanggal din, may tataboy din yung virus. Stomach acid. Oh, mahirap yata makalusot dyan ng kahit na ng virus. In fact, if you put a piece of metal sa stomach natin, susunugin yan ng muriatic acid dyan. That is highly acidic. Ganun katapang yung acid stomach. Sa mata, tears. Tears is a form of protection din. Pag pumatong dyan ang bacteria or virus at na-irritate yung mata natin, nag-lacrimate, yung dami ng tears, iniluluha niya, tinatapon niya yung mga parasites. Kaya it is again a form of defense. Yung skin natin is topped by a layer of dead cells. Walang virus na makakadaan sa dead cells. Kailangan ng virus alive cells that are living, no? Scabs. Yung scabs, yan yung natutuyo pagka nagkakaroon ng break sa skin. Skin is proteinaceous, but then again, it does not allow pathogens, parasites to get into the wound. It's a form of protection. Kahit nasugat tayo, may protection pa rin tayo. And then there are the proteins na nire-release ng mga sub-epithelial cells, no, in response to the entry of foreign matter. Pag may nakapasok na mikrobyo under the skin, they release epithelial defensins. Mga proteins yan na nagpapadala ng signal doon sa nakatagong cells. Tagong cells, no? Yan yung mga nagre-respond sa infection. Mga T cells, mga plasma cells, then they can respond faster doon sa entry ng microbes. Then, at the same time, may nag-aabang sa ilalim ng tissue natin. May nag-aabang dyan ng mga phagocytic cells. And the phagocytic cells themselves also contain defensins. Once they sense that there is foreign matter, non-specific, hindi specific, gagawa siya ng defensins, phagocytic defensins, para ma-recruit yung mga T cells. Yan yung mga killer cells, natural killer cells, na nasa other parts of the body. But on top of that, there are certain microbes, no, na friendly, na hindi pathogenic, na part of other microbiome, no, that may also produce defensins. No? May mga bacteria na normal sa balat natin, sa ibang parte ng katawan natin, kapag nakakita ng offending agent like a virus, they will make microbial defensins, and these can be sent across. They can be sent to the T cells and B lymphocytes to make an appropriate response. Pero non-specific pa rin yan. So these are anatomical and chemical barriers. Pag-usapan natin yung intrinsic barriers kasi pag nakalampas dun sa first barrier yung mga virus, nandyan yung intrinsic barriers. Yung interferons, no? Interferons is an overlap. Maraming klaseng interferons. There are at least 3 kinds. Pero yung interferon alpha, it's always there, nasa cells yan. Pag may nakapasok na cell sa virus, magre-release yung cell ng interferon alpha to warn adjacent cells to be ready para pagka dumating sa kanila yung invading organism or virus, they are ready to react. So that's interferon. Yung ibang interferons, there are other pathways and they interlock with the other defenses. Intersect din yan doon sa iba pang defenses. Hindi lang sa intrinsic, pati sa innate nagpa-participate din ng interferons. Pero yung gamot na binibigay, di ba? They tried interferons sa COVID-19 Pero walang nagagawa kasi it's non-specific At saka you have to give it very early kung sakali. Pagka may infection na halos wala na siya magawa. This is something that you should not memorize. No? Gusto ko lang i-impress kayo sa ating lahat, no, na may iba pang mechanisms ng cellular defenses against viruses. This is a slide from a virology lecturer, si Vincent Racaniello sa Columbia University, that I really do not understand. Yung siya lang nakaka-explain niya, no? Ang naintindihan ko lang dyan, no? Kapag ang virus lumabas sa cell, papasok yan sa next cell, no? At mag-divide na naman yung kanyang nuclear material. Pero in the presence of apolipoprotein B mRNA editing catalytic polypeptide, yung ApoBec na yan, no? Sasama siya dun sa viral particle. At pag sumama siya sa viral particle at nag-invade ng bagong cell, it will cause a mutation that will cause the RNAs to be chopped into smaller pieces and they can be degraded. So, may cellular and the biologic defenses din pala na binibigay sa atin si Lord. That is what struck me. Ako, yung mga mechanism dyan, ang hirap ng tandaan, no? But there is something else na tinuturo si Professor Racaniello sa lecture niya Sa cellular realm pa rin, ano? May isa pang defense mechanism na tinatawag na epigenetic silencing. Yung mga cells natin are making a lot of histones, mga protein substances na yan. Kapag nakakita sila ng abnormal RNA or DNA or abnormal nucleic material doon sa cytoplasm, didikit sila doon. At hindi nila i-allow na mag-replicate or mag-translate yung RNA. And the RNA will remain there silenced. Kaya ang tawag epigenetic silencing. Again, it's a cellular defense mechanism. Bigay pa rin ni Lord yan. It is there. No? Yung autophagy at apoptosis, they are also cellular mechanisms. Ang cells natin, no, pagka nakita niya na natatalo na siya, namamatay siya because of an infection, it will die by itself. It will set off a cascade of reactions that will cause bleeding and cell death. Ang tawag doon, apoptosis. Pag namatay yung cells na yan, all the nutrients, no, na mapupunta sa maliliit na pieces, tinatawag na apoptotic bodies, they can be reused again to make new healthy cells. So that is the function of apoptosis. Normal yan. And many cells, no, lalo na yung mga phagocytic cells, yung mga killer cells, kukunin nila yung apoptotic bodies na yan. I-engulf nila in a process called phagocytosis. So they usually come together, apoptosis and phagocytosis. And what is good dito, may overlap na naman ito no, with the specialized immune system, immune compartment of the immune system. Kasi pagka na-engulf niya yung mga abnormal antigens, RNAs, DNAs, pinipresent niya yan doon sa mga B cells and T cells to be remembered. So, again, that is a system that is given to us para hindi tayo sitting duck na lang against any kind of virus. Another intrinsic barriers would be the microRNAs. Yung mga microRNAs, pinagtatalunan pa niyan nila kung present yan sa mammalian. Pero meron siya sabi, possible daw eh. Ang sinasabi nitong actually theory, pero na-prove nila sa ibang cells to eh. There are dicer proteins in the cytoplasm, so that when a virus enters and senses a double-stranded RNA, double-stranded RNA does not happen in our species. Ang double-stranded sa atin, DNA. Pero pag nakakita tong dicer molecule na yan ng double-stranded RNA, sinachop niya into smaller RNAs, which are called siRNA or small interfering RNAs. So that when a new virus enters, those small interfering RNAs na tawag, they interfere with replication of the RNA of the virus. Kaya hindi natutuloy yung replication of virus. And this is again a defense mechanism provided by the cell. And that is the same with the CRISPRs. Yung CRISPRs usually sa bacteria yan, pero lahat naman tayo, normal naman yung bacteria natin, ano? Yung CRISPRs, yung clustered regularly interspaced short palindromic repeats, mga paulit-ulit yan, na segments of RNA that interferes with the replication of the viral nucleic material. So we have a lot of defenses. But even though we have lots of defenses, through time, yung virus dahil sa mutation, nakakahanap pa rin siya ng paraan para makabit around those defenses. But do not forget, hindi tayo pinabayaan ng Lord. Dami nating defenses. Then, we have the innate immunity. Innate, ito hindi laging nandyan, It has to be activated, Pero, this immunity is non-specific. Kahit anong virus na pumasok, it will kill that virus. Innate immunity. But it entails a little immune response. Nandyan yung mga natural killer cells, Actually, yung mga phagocytes na-expose sa antigen o nakakuha ng antigen, ipipresent niya yan sa T helper cells. Yung T helper cells pupunta ngayon sa mga nodes, lymph nodes. Nandun naghihintay yung mga natural killer cells. Dadalhin niya dun yung message, yung antigen. Kaya mapupuntahan niya ngayon yung mga infected cells na merong ganong klaseng antigen, and the natural killer cells will usually engulf the infected cell. Mamamatay yung infected cell, but it will become substrate for the production of newer, healthier cells. So, that is innate immunity. Ang ganda ng process na binigay sa atin, Lord. Yung complement, is another one. Ako hindi natin pag-usapan yan. Isang buong lecture yan. Isang oras yan. But the complement is a cascade of reactions. Maraming proteins yan, that will stimulate the entry of more phagocytic cells. More phagocytic cells from the nodes and from the other parts of the body. There are different pathways wherein the cascade goes through. We are not going through them one by one. Kasi ako, kailangan ko pag-aralin uli yan. Pero kita nyo, hindi tayo pinabayaan ni Lord. Binigyan niya tayo ng maraming defense mechanisms. How about yung mga cells na nagpe-present ng iba't ibang antigens, Meron tayong mga cells sa ilalim sa subcutaneous area. Ang tawag doon dendritic cells. DC yan, dendritic cells. Marami siyang antigens around Namamana natin yun yung mga antigens na yan Pero it's still not specific kasi namana natin. But then again, it can be activated by the presence of virus. It talks to helper cells. The helper cells, pagkatapos ina-activate niya yung mga polynuclear cells para bumalik at mag-provide ng respawn para patayin yung virus. And not only that, marami pang antigen-producing cells, yung mga plasma cells nasa sa ilalim ng epithelium ng subcutaneous area they also participate in antigen presenting cells. Then we have neutrophils. Yung neutrophils, alam na natin yan. Kasi pag nakapasok siya sa infection site, nagiging natural killer cells ang mga neutrophils. And then, of course, we should not forget the participation of the cytokines. It's part of the innate defense mechanism. Saan ba nanggagaling yung cytokines? Ang daming gumagawa ng cytokines. Yung mga modulators of inflammation and inflammatory response. Those are the cytokines. I'm not going through them one by one, no? Pero we have to understand at this point, no, that a gamut of cells participate, no? Macrophages, lymphocyte, mast cell, endothelial fibroblast. Hindi tayo pinabayaan ni Lord. Maraming gumagawa ng cytokines. In fact, no, doon sa severe COVID niya, nakakalungkot naman, nagkaroon ng abnormal cytokine response. Sumobra yung cytokine response. Ang tinatawag na cytokine storm. And there are cases na wala na yung virus. Nandun pa rin yung virus, hindi mawawala ng 100% yan. Hindi na siya nase-shed off as infective, non-infective na yung mga individuals, pero nagsa-cytokine storm pa rin sila. And those are things that needs explanation pa. Siguro after another quarter or 6 months, na-explain nila lahat yan in more details. But nevertheless, do not forget, dami nating defense mechanisms na binigay ni Lord, hindi tayo sitting duck. Finally, yung adaptive immunity. And I told you earlier that I will not discuss this in detail. Ang importante lang, no? You know that there is beta lymphocytes, T lymphocytes na na-recognize into memory yung specific invading particles. Kung yan ay virus at nakaabot yan sa lymphocytes, na memorize nila. Sa T lymphocytes nga, meron special T cells na tinatawag na memory T cells. Once they have the memory, every time there is another infection of the same kind, memorize na niya yun. Papadala na niya sa killer cells. Stimulate na kagad yung killer cells para patayin yung invading particle. No? Before I close this, no, I should not forget to remind you, no, yung difference ng specific at saka yung non-specific immunity, no. Yung specific immunity, kailangan talaga ng antigen to stimulate that response. Kaya yung mga bata na hindi pa na malakas pa yung kanilang mga first three defenses, yung intrinsic, yung innate, at saka yung chemical and atomic barriers, lakas nilang lumaban sa lahat ng invading organisms, invading viruses. But as we grow older, kailangan natin talaga ng ma-develop ang innate immunity. Napaka-importante talaga ng vaccines. Yung nga lang, pag may may bagong invader like SARS-CoV-2, then it will tell us another story. It is a completely new story. Bago sa atin yan. Yan, sa bagong testament naman, kinonfirm lang ng ating Bible na the Lord is faithful, He will strengthen you and protect you. Hindi tayo pinababayaan ni Lord, no? Kaya dito sa lecture na to, no, kung sasabihin natin, no, na all the while akala natin, no, nilalayo tayo ni Lord dahil dito sa sakit na to, hindi pala. All the way, kasama natin siya. Kasama natin siya, tinutulungan siya tayo. Pero, no, kailangan tulungan din natin ang sarili natin. E paano natin tutulungan ang sarili natin? Gamitin natin ang science. Sa science natin nalaman na nandito si Lord. Kaya sa science din natin malalaman kung paano natin matutulungan yung sarili natin. Wear mask. Mask tayo lahat. Maglinis tayo ng kamay madalas. Saka yung social distancing. Yun ang tinuturo ng science. Si Father, nakalimutan. Hinihintay ko sabihin niya, huwag nang maghugas ng kamay. Buti nila, hindi niya sinabi yun. Na sinabi lang yan, pwede na daw hindi mag-social distancing, pwede na daw hindi mag-mask. Teka muna, hintayin natin na sumagot si Lord sa atin through science din naman. Hindi naman tayo binibili ni Lord. Kaya next time, pag nagkaroon ulit tayo ng time, ang magandang pag-usapan yung tinatawag na adaptive immunity. And that will include yung ano ba talaga yung bakuna? What is vaccines? Siguro in a manner na maintindihan natin lahat, na mai-explain natin sa pasyente. Usapan natin yan next time. So thank you very much for listening. Papasalamatan ko ulit yung guests. Ako, thank you At pinayagan nyo kaming mag-lecture ng mga topics na pinaniniwalaan namin na makakatulong sa aming mga members, maitutulong din namin sa mga pasyente. Thank you for being with us. Marcy?
Yes. Thank you, Kuya, for that enlightening lecture. Yan ang tatak, Kuya Elwin. Making complicated lectures to be very simple para maintindihan natin. So, thank you, Kuya. So, let's go now to our clinical part entitled Treatment of Diabetes in Patient with COVID-19. I'll introduce to you our speaker. He's a faculty of the RMMC ISDFI, the Vice President of the Consortium of Government Diabetic Clinics, and the Present Secretary of the ISD Alumni Association, and the Present Secretary of the Philippine Society of Diabetologists. Without further ado, Jamie, I'm introducing to you Dr. Jamie Agra. Jamie.
Yes, okay. Slide share. Wait. Sandali lang. I think may pre-present lang sandali ang Gets Pharma bago ako mag-start.
Oh, sige.
Okay.
This is a story about making a difference. Did you know that every 6 seconds, someone dies from diabetes? The clock is still ticking. It's time to rise to the challenge. And Gets did. And Insiget was born. At the moment of its inception, Insiget is already different. Derived from the amazing Pichia strains, it is the only one of its kind that can produce an insulin similar to a human protein. And using Getz Lab's state-of-the-art facility, the insulin crystals are thawed at a normal pace, a step ahead of the required specifications of the World Health Organization. Now, that's already a big difference. Because Getz Lab is one of the only 33 quality control laboratories in the world, pre-qualified by WHO. It also utilizes the unidirectional airflow, which means it does not allow any particles floating in the air, even the tiniest particle, with a size range of 0.2 micron. That's why it is certified Class 100 with 99.99 sterile air. But did you know that Getz Labs has one of the world's best WFI, or water for injection? Because Getz believes that the water or diluent is as important as the ingredient itself. That's why they use the spring water concept that utilizes the continuous flow of water in one direction, thus purifying water from large particles and bacteria. In addition to this, they have a multi-purification system where filtration, distillation, purification happen, and ultraviolet filters are used. It even uses steam water for vial washing. And since the entire procedure is automated, it only allows minimum human interference for assured quality. But Getz Lab's care for Insiget doesn't end until it's made. It goes beyond it, even during storage. Insiget is stored in temperature-controlled warehouses and monitored for 24 hours all year round. And when Insiget is delivered to you, it is via cold chain delivery. So you are guaranteed of Insiget's freshness. Insuget is also easy to use. Step 1. Roll the vial between the palm of your hands till the liquid becomes uniformly white and cloudy. Step 2. Draw air into the syringe equal to the dose of insulin you wish to take. Step 3. Inject the air into Insuget 70-30. Step 4. Draw Insuget into the syringe. Avoid air bubbles. Step 5. Check the recommended injection sites. Step 6. Pinch your skin and inject Insuget into the skin fold, only at 90 degrees. Join us, and together, let's make a difference in the lives of Filipino diabetic patients. Make a difference with Insuget.
Okay. Okay. My topic, naririnig na ako. Hello? Hello?
Yes, yes, go ahead.
Kala ko wala akong volume eh. Okay. My topic is about treatment of diabetes in patient with COVID-19. So the learning outcome for today's topic is to discuss the underlying mechanism in the risk for mortality in patients with COVID-19. I will explain also the effect of COVID-19 infection on glucose control, the challenges in the management of diabetes during pandemic will be presented also in this lecture, as well as we'll discuss the role of diabetes medication among people with COVID-19 infection, recommendation treatment strategies of hyperglycemia in people affected with COVID-19, and special issues in patients with COVID-19 infection and diabetes will also be discussed. So, according to the available evidence, people with diabetes do not have a higher susceptibility to SARS-CoV-2 infection. But diabetes is associated with prognosis wherein mortality in hospitalized population. A larger study in patients with COVID-19 in China indicated that patients with diabetes has a threefold higher mortality rate compared with the mortality rate in COVID-19 patients overall. As the latest research demonstrated that blood glucose was a representative indicator of multi-organ injury and earlier predictor for poor outcome and death in COVID-19 patients. Here in this slide, you will see how the possible generation and effect of hyperglycemia in COVID-19. Beta cell is infected by SARS-CoV-2. It may reduce insulin secretion. At the same time, the cytokine storm that sometimes accompany the SARS-CoV-2 infection may induce or worsen insulin resistance. With these both conditions, it may lead the appearance of worsening hyperglycemia, which in turn may further worsen or induce insulin resistance. Moreover, hyperglycemia during COVID-19 through non-enzymatic glycosylation of ACE2 worsening the COVID-19. Hyperglycemia therefore may induce endothelial dysfunction and thrombus generation, leading to more multi-organ damage. There are several reasons for glucose fluctuation in patients with diabetes and COVID-19. In this, you can see that there may be interruption or non-standard treatment with oral glucose-lowering agent in an isolation ward resulting to glucose fluctuation. Irregular diet, induced exercise, GI symptoms such that affect diet can also result glucose fluctuation. The use of glucocorticoid in the treatment plus the stress condition like infection can increase and move to a sharp rise of glucose among patients with diabetes. The fear, anxiety, and tension may also a triggering factor that can increase the glucose level among patients with diabetes. In COVID-19, can cause human body to produce a large number of inflammatory cytokines and lead to an extreme stress in some severe and critical patients. There are many interruptions for the non-standard treatment with COVID-19. Because of the current situation wherein there's an interruption like the home quarantine, most of our patients having the shortage of the medical resources such as their medication, seeking a consultation with the doctor because of this pandemic. And because of this pandemic restriction brought so much panic, not only to us, but more so among the people with diabetes. In this slide, we'll show the synopsis of the reciprocal effect of diabetes in COVID-19 and COVID-19. The relationship between diabetes and COVID-19 is by univocal. On one hand, people with diabetes have the worst outcome because of the multiple associated conditions enhancing the risk. Hyper-SARS-CoV-2, because of its tropism for the beta cell, might cause new onset of diabetes or sustained hyperglycemia at hospital admission. Impairment of this beta cell function, along with the inflammatory cytokine and counter-regulatory hormone response, can precipitate or worsen the metabolic control in patients with diabetes, like the DKA and the HSS. Hyperglycemia on admission plus the new onset of diabetes and this acute worsening metabolic control in patients with diabetes can further worsen, giving a poor outcome for patients with diabetes infected with COVID-19. How about choosing the glucose-lowering drug during COVID-19? What are the drugs that can be taken and which one cannot be taken? For the non-insulin therapies, as previously published, guidelines recommend discontinuation of the non-insulin medication and initiation of insulin therapy for patients with diabetes or newly recognized hyperglycemia at the time of hospital admission. But in other journals, it states that to optimize diabetes management, as previously established, international guidelines with relevant and specific national adaptation and reimbursement criteria for glucose-lowering drugs must be considered. In this slide, you can see here the proposed mechanism of concern and benefit of using glucose-lowering agent in the patient with diabetes and COVID. In this first slide, it's about the metformin, pioglitazone, and the sulfonylureas. With their relation to the ACE2 expression in experimental model or human, it said that the pioglitazone had increased ACE2 expression in the liver in mouse and decreased the ADAM17 in skeletal muscles in human. With regard to their past humans proposed benefit, proposed concern in COVID-19 patients, with metformin use, the chance of lactic acidosis in sick patients and renal dysfunction has been seen. While with pioglitazone, an increased chance of COVID-19 infection through ACE2 overexpression, while in sulfonylurea, a fear of hypoglycemia. How about their benefit when used in patients with COVID-19? With metformin, it's been proven that a potential cardiovascular benefit can be seen. Reduction in pro-inflammatory cytokine can reduce cytokine storm and induce damage with pioglitazone, but non-specific has seen with sulfonylurease. But using this, bakit nagganyan? Sorry. Sorry po. But using this metformin, pioglitazone, and sulfonylurease can be continued with a mild to moderate risk of COVID-19, but cannot be used or should be avoided for those having severe and critical stage of COVID-19. While using DPP-4 inhibitor, SGLT2, GLP-1 receptor agonist, and insulin, with their relation to ACE2 expression in experimental model of human, it seems that SGLT2 increased ACE2 expression in kidney and in human, while in GLP2 in lungs and in the heart. But with the DPP-4, no such association with severe MERS-CoV infection in transgenic mice expressing high with DPP-4. But with insulin, it increased the intrarenal ACE2 expression by reducing renal ADAM7 in diabetic mice. With regard to the proposed concern of using this oral glucose-lowering drug to patients with diabetic with COVID patient, there are seen to be increased in the euglycemic DKA and incident of hypoglycemia with SGLT2 and GI side effect with those using GLP-1 receptor agonist, and no concern between DPP-4 and insulin. At their proposed benefit to be used in those infected with COVID-19 for patients with diabetes, DPP-4 inhibitor had shown an anti-inflammatory activity. Therefore, proposed benefit is SARS-CoV-2 utilize DPP-4 as entry receptor if mutated. And for SGLT2, the beneficial for cardiorenal outcome was observed and may be protective. As there was a new ongoing study done, which is the DARE-19, that will study the benefit of this SGLT2 inhibitor, specifically using the dapagliflozin. While for the GLP-1 receptor agonist, it's been seen that beneficial with cardiovascular effect has been observed and may be protective. But for insulin, anti-inflammatory positive anabolic effect make insulin as the first choice in any stage of the infection of COVID-19. Again, with their remark, DPP-4, SGLT2, GLP-1 receptor agonist can still be used, but only in mild to moderate COVID-19 stage of the disease. While in the severe and critical case, this drug should be avoided. Not like with the insulin, at any kind of the stage of COVID-19, it can be continued. Now let's see the role of DPP-4 in disease severity. Excuse me. Here, the viral strategy had effect for the rapid replication and immune invasion. With the confirmed positive advantage to SARS-CoV, comorbidities like hypertension, diabetes, COPD, CVD, and CVA has made a bigger odd ratio for death for the SARS-CoV diabetes. and it tipped the balance in favor for the SARS-CoV with the presence of these comorbidities. As the role of DPP-4 inhibitor in immunomodulation and cardiorenal protection in COVID-19 is still questionable and still ongoing studies are being done if DPP-4 can be used in patients with COVID-19. As they said, the simplified mechanism for possible benefit of DPP-4, they said that with DPP-4, it can have an effect of anti-inflammatory, anti-proliferative, and anti-fibrotic for those patients using this drug for COVID-19. There are several debates and journals being about DPP-4. As they said, another name for DPP-4 is CD26. Is a transmembrane on cell and soluble ectopeptidase largely expressed in human tissue, including airways, lungs, and leukocytes. Particularly, DPP-4 is specifically involved in MERS pathogenesis given that it mediates MERS-CoV-2 internalization in host cell. But with regard to the role of DPP-4 internalization to SARS-CoV-2, no actual data support for this, and further study were needed to verify this aspect and for demonstrating a clear protective effect. However, DPP-4 inhibitor had shown to potentiate immune response by increasing T-cell survival, thus enhance immune response and possibly playing a relevant role in reducing the onset for the progression of acute pulmonary manifestation in COVID-19. Prior to COVID-19 pandemic, IV insulin infusion were recommended for glycemic management in majority of patients with critical illnesses, and nursing intervention to monitor blood glucose every 1 to 2 hours with frequent adjustment to insulin infusion rate. So ito yung ginagawa natin nung wala pang COVID. But during the COVID pandemic, glycemic control not achieved with subcutaneous insulin injection, IV insulin infusion protocol alone, plus in combination with basal insulin need to be implemented. And to minimize nursing time of exposure, frequency of blood glucose monitoring should be done to every 4 to 6 hours when the insulin infusion rate are stable. Here showing you the therapeutic principles for the glucose management in COVID. Insulin treatment is still the first choice if diabetes is combined with severe infection. For non-critical patients, insulin subcu injection is recommended and the basic dosage can be referred to an out-of-hospital dosage. While for critical patients, continuous subcutaneous insulin infusion is recommended. While IV insulin treatment should be started in combination with aggressive fluid infusion if serious glucose metabolism disorder with water and electrolyte and acid-base disorder is seen. Glucose management strategy are different for patients with diabetes and COVID depending on the type of diabetes. For the type 1 DM patient, insulin pump or basal plus bolus insulin treatment is the optimal regimen. Recommend insulin analog as the first choice. Insulin treatment should be individualized. While for the type 2 DM with mild COVID, patient with low moderate glucose increase and non-insulin diabetes drug can be continued and used. But for patients with fever or treated with glucocorticoid, insulin treatment is the first choice. So much so, with a critical patient, IV insulin is also recommended. While for patients who are on glucocorticoid, it is important to monitor blood glucose after lunch and before dinner, as glucose-induced increased glucose often occur between after lunch and before sleep. Again, insulin is the first choice. So again, glucose should be monitored after lunch and before dinner because during that time, glucocorticoid-induced increased glucose often occur between after lunch and before sleep. So what do you mean by scheduled insulin therapy? It means that basal insulin administered, preferably long-acting insulin like glargine U100, and prandial insulin for patients who are eating or receiving supplemental enteral or parenteral nutrition and can be used as a correction insulin for blood glucose above the target range. In this slide, you can see the diabetes injective treatment, a potential aid against COVID-19. Type 2 diabetes and COVID-19 share a common soil of chronic inflammation. High level of inflammatory cytokines, interleukin-1, interleukin-1 beta, interleukin-6, and tumor necrosis factor alpha stimulate the secretion of GLP-1, which in turn is able to reduce their circulating level, hyperglycemia, and inflammation. Similarly, with the use of insulin, it lowers both glucose level and inflammation. The combination of this GLP-1 and insulin provides synergistic glucose lowering and anti-inflammatory effect. Administration of the two drugs with a single daily injection avoid unnecessary exposure to COVID-19 patient, minimizing the risk of infection transmissions were being minimized. And using both GLP-1 receptor agonist and insulin along or in combination may be an effective therapeutic option for asymptomatic and non-critically ill COVID-19 diabetic patients. There are several concerns with the proposed for therapeutic agent using for COVID-19 among patients with diabetes. Like in the case of chloroquine or hydrochloroquine, it's been found that it can cause hypoglycemia. So caution should be with using this when treating the patient diabetic with insulin and insulin secretagogue. While for the antiviral such as lopinavir, ritonavir, hyperglycemia are noted and deterioration of glycemic control has been seen with the use of this antiviral therapy. As well as with the glucocorticoid, hyperglycemia has been seen and more susceptible to secondary bacterial infection. While with remdesivir, it's been seen that it will lead more on hepatotoxicity, and it's been advised to be cautious when treating with statin and those with pre-existing fatty liver diseases. There are special issues for patients with COVID-19 infection and diabetes. When a diabetic patient infected with COVID-19 using glucocorticoid, protocol using intensified basal bolus insulin regimen alone or in combination with NPH are advised. It being demonstrated that being effective in patients receiving longer-acting glucocorticoids such as dexamethasone. While an accompanying in continuous IV insulin infusion become necessary for patients with persistent glucocorticoid-induced hyperglycemia if glycemic control is not achieved with subcutaneous insulin. With NPH pharmacokinetic as coincide with those of prednisone and methylprednisolone, making an alternative therapy for managing hyperglycemia in patients receiving this therapy, glucocorticoid. Again, with hydrochloroquine agent, again, is still under investigation for COVID-19 that has relevant to glycemic management. In one small trial about the use of hydrochloroquine resulted in improved beta cell function and insulin sensitivity in obese subjects with insulin resistance but without diabetes. So meron naman palang nakikitang kahit pa paano maganda. In a systematic review of 18 studies, a substantial reduction were observed for HbA1c, fasting, and postprandial plasma glucose level. When using hydrochloroquine and patient treated on insulin, insulin dose should be reduced for an equivalent of 30%, as may be required for some patients who are receiving this to avoid hypoglycemia. There are other medications used in our hospital, even an outpatient setting for diabetes who are infected with COVID that can affect blood glucose level. And one of that is anti-tussive syrup that containing glucose that can contribute to hyperglycemia. Here, most patients with type 2 diabetes have other component of metabolic syndrome, like hypertension and dyslipidemia. Therefore, continuation of this appropriate treatment in all patients is of crucial importance. Like statin, it has been shown to restore the reduction of ACE2 induced by high lipid such as LDL. With its pleiotropic anti-inflammatory effect, has been attributed to the upregulation of ACE2. It was believed that ACE2 expression is associated with both infection and mortality rate in COVID-19. Therefore, statin should not be discontinued because of the long-term benefit and potential for tipping the balance toward the cytokine storm by rebound rise of interleukin-6 and interleukin-1 beta if they are discontinued. With a close link between diabetes and cardiovascular disease, control of lipid concentration in all patients with COVID-19 is highly recommended. Another thing is with the use of the antihypertensive ACE1 and AR2B could increase the expression of ACE2, which could accelerate entry of the virus into the cell. Remember before na umugong yan na bawal nang wag daw na kung talaga itutuloy yung mga ACE inhibitor or AR2, but in this it was been proven by some cardiologists and study that ACE inhibitor and AR2 blocker used could protect against severe lung injury following infection of COVID-19. As currently available evidence, patients should continue this antihypertensive regimen, and it was endorsed in the recent position statement from the European Society of Cardiology, the Heart Failure Society of America, American College of Cardiology, and the American Heart Association strongly recommend the continuation of treatment using ACE inhibitor and anti-receptor and A2 receptor blocker. How about the monitoring of patients who had infected with COVID-19? Timely glucose monitoring has been shown related potential risk during this pandemic, wherein the traditional glucose monitoring and frequent invasive blood sampling means increased exposure of our healthcare worker as an occupational hazard closely contacting the COVID-19 patient. Now, considering this increased occupational exposure, the flash glucose monitoring device, which is popularly known as the Freestyle Libre, measures the amount of blood glucose in the fluid under the skin, which is the interstitial fluid. This Freestyle Libre has a small sensor wire inserted under the skin that has sensor to see the blood glucose level. And it used this smartphone app that used to scan the sensor that actually lasts up to 10 to 14 days. The only disadvantage of using this Freestyle Libre, unlike the continuous glucose monitoring system, it does not have an alarm or a hypo or hyperglycemic warning. So, in treatment summary for diabetic patient with COVID-19, for those having mild stage of COVID-19, both oral glucose lowering agent and insulin treatment can be maintained, and it is necessary to adjust or to a regional regimen. For those who have progress of COVID-19 can be rapid and worsen with hyperglycemia. So it's recommended that patients with diabetes with COVID-19, even mild, to increase glucose measuring frequency and see if there's a need for a glucose target to be achieved to prevent hyperglycemia. While those patients with moderate stage of COVID-19, original regimen, if patient mental condition, appetite, and glucose control are within the normal range, and switching of oral glucose lowering agent to insulin for patients with obvious COVID-19 symptoms who can eat regularly, and suggest the switching of the premixed insulin regimen to basal bolus regimen or insulin pump to flexibly manage the glucose control. Again, for severe and critical, IV insulin should be the first line of treatment. For the IDF, they said that there hasn't been enough evidence of evidence-based medicine for COVID-19 management in diabetes. They referred to the standard of care of type 2 diabetes. IDF refer to follow the recommendation of the 6-day rule for patients with diabetes and COVID-19 for better care and improved prognosis. What is 6-day rule? 6-day rule stands for S as sugar, I for insulin, C for carbohydrate, and K for ketone. These are the general advice for managing diabetes during intercurrent illness. So, pre-existing type 2 diabetes is associated with worsened outcome of COVID-19, regardless morbidity or mortality. Mortality is lower in diabetic patients with good metabolic control compared to poor metabolic control. And the management consideration for people with diabetes is that for asymptomatic infection, home and hospital care with continued usual therapy are advised, but for symptomatic and non-severe, with hospital care, usual treatment should be used with caution, especially with the SGLT2 for the risk of euglycemic DKA. And for severe, of course, ICU setting with IV insulin should be used for this critically ill patient. For the general recommendation during COVID-19 pandemic, again, physical distancing, personal hygiene, hand washing, masks are must to be done, and prevention, not only for diabetic, but for all of us. For the diabetic patient, they have to prepare all the list medication and test strip for glucose monitoring and should have a stock of at least 3 months for their medication. They should be advised, don't neglect exercise, diet, and blood glucose as well as BP control. Advise them to communicate using the telemedicine with their healthcare provider. Maintain appropriate level of hydration, exercise, and glucose and ketone monitoring. Among hospitalized subjects with type 2 DM, medication may need adjustment, and insulin is often the prepared glucose-lowering treatment. There are several potential studies being done for COVID-19 and diabetes. A global database has been started to collect information on people with COVID-19 and high blood glucose level in people without prior history of diabetes. So, nagiging at risk ba dahil lang sa COVID-19? And many questions to address, for example, can COVID-19 induce type 1 diabetes or a new form of diabetes? Can sudden onset of diabetes become permanent in people who had COVID? Will the virus tip people who are on the way to develop type 2 DM into diabetic state? These are the new potential studies being done for COVID and diabetes. Here is a risk assessment form being used and suggested by the Finnish Diabetes Risk Score form. They said that using this questionnaire can be useful for detecting patients with COVID-19 who are more likely to have or have an outcome of diabetes. That using this quick and easy way to detect potential undiagnosed without the laboratory measurement. That takes only 5 minutes to build up and at using this questionnaire for all suspected and confirmed cases of COVID-19. Siguro pwede natin itong gawin pag kahit sa OPD natin para ma-detect lang natin kung yung patient natin may risk na ba dun na maging diabetic dahil sa nag-positive siya sa COVID. Pero sa triage to, hindi syempre sa clinic natin. So together, let's unite for diabetes and win the war against COVID. I think that's my last slide. Thank you for listening.
Thank you very much. Thank you very much, Dr. Jamie Agra, for that extensive review on the treatment as well as monitoring of diabetic patients. So can we now open the floor for questions and answers from our viewers? So we have the first question here from Dr. Baltimore. Among diabetic patients with COVID-19, what is the common picture of blood sugar? Is it hyperglycemia or hypoglycemia?
Jamie niya tayo.
Okay, Jamie nga, kuya. Yung
Mostly,
question na yun.
because of this pandemic, mostly are noted to be in hyperglycemia kasi nga hindi nakakabili ng gamot, nakamiss ng gamot. Kaya usually nakikita kahit hindi siya diabetic, with all the stress, tumataas yung sugar. Kaya there are coming studies na kung yung COVID ba talaga ang reason para magkaroon ka ng diabetes or nagkataon lamang.
Alam mo, tama sinasabi ni Jamie eh. Kasi kung ang tinitingnan mo lang ay pathophysiology, no? Hindi mo patitreat yung majority ng diabetes na nagkaroon ng COVID, lalo na yung mga may mild to moderate na hindi na na-hospitalize. Because diabetes is not only biochemical, it's also sociologic. Yun din kung ano ang nangyayari sa society. Nagkaroon ng lockdown eh. Walang trabaho, walang pambili ng kapot. Hindi makalabas para pumunta sa putikan. And those are things that we should all be able to address. And thank you, Jamie. Tama yung mga concerns na nagpapataas ng blood sugar ng pasyente. Pati nga daw yung totoo yan yung isang pasyente, no? Kaya tumaas yung blood sugar during the lockdown kasi isang pindot lang ng cellphone, nandyan na yung pagkain sa pintuan.
Yes, sir. Hindi na sila
Okay.
nakakapili ng tamang diet.
Pagkain. Oo, tsaka walang exercise kasi nakaano lang sila eh.
Upo.
Nakaupo or
Bawal lumabas.
bawal lumabas doon sa sa mga nakakondo, no, na napakaliit lang yung space na kanilang ino-occupied. So, ito naman kuya, no, ang question ko naman, nakita ko so I appreciated what God has given us, the physical barrier. Pero tayo ding mga human ang sumisira nito. Ano-ano ba yung mga ginagawa ng human na nasisira yung physical barrier na yan?
Unhealthy lifestyle.
Yan.
Nababawasan yung mga barriers na yan. Yung palang, yung smoking, tsaka pollution, no? Yung mucus na naiiba yun, hindi matanggal ng respiratory tract yung mucus pagka smoker. Nawawala yung ciliary movement. Yung mga unhealthy practices na yung overweight, which is a long-term inflammatory condition din, may effect din yan sa mga natural at saka intrinsic barriers. Maraming nakaka-effect yan. Yung exercise, ang feeling ko, ang effect nun sa totality ng individual sa totality ng individual. Kaya pagka magandang kondisyon ng katawan mo through diet and exercise, yung mga physical barriers, intrinsic barriers nagiging strong din siya. Ngayon, bihira pag-aralan yan, lalo na ng mga pharmaceutical industries, no? Kasi walang ROA. Pagka ang pinopromote mo, yung intrinsic barrier, yung chemical barriers, pero nag-aaral na yung mga tinatawag nating supplements. No? At magaganda rin yung mga trials nila. Like for example, yung daw garlic, nag-i-improve yan ng innate. At
Naghang si Kuya.
Naghang si Kuya. Kuya, naghang ka.
Certain vegetables, malunggay daw, nakaka-improve din ng immunity. Although, hindi nga well-studied kasi walang gaano magkakaroon ng Pero in general, no? In general, if you have a very healthy lifestyle, no? Exercise ka, maintain mo body weight mo, makain ka ng tama, chances are, the system, intact yung lahat ng defenses niya.
Kuya, yung mga nagpapaganda kaya sa skin, meron kayang
Papaganda
yun?
sa skin?
Oo, sir. Di ba daming mga beauty products sa skin? Nakakaano kaya yun sa barrier natin? Nakaka-decrease sa barrier natin.
Nako, walang study dyan, ano? Pero kailangan mo ng evidence para magsabing may effect yan, ano? So, totoo lang, I do not know. I have not seen a study that will say that it has an effect. No? Tanong natin ng dermatologist kung meron talaga effect. Pero at this point, no, hindi ko naman sasabihin na meron siyang good or bad effect. Wala akong alam when that comes.
Okay. Thank you, Kuya.
Baka si Danny may alam.
Ay, wala po, sir. Baka pagka si Vicky Bello meron. Ito ulit, another question.
Nawawala ka, Dan.
Pag si Vicky Bello, sir, sasabihin niya merong effect na maganda siya.
Nawawala si Danny.
Hindi, sir, ikaw ang nawawala. Ikaw po nawawala.
Oh, yes?
Ikaw po ang nawala.
Nawawala ka, Dan.
Mars, Ate Marcy, nawawala
Okay.
ako.
Hindi, si Kuya nawawala. Kuya, kayo po
Kuya,
nawawala.
Narinig nila ako.
Si Kuya ba?
Ayaw nyo
Kuya,
makinig sa
okay.
sa warning ng PLDT. Ito na yon.
Ayan. Another question kay Jamie from Dr. Albert Bunyi. In severe COVID-DM patient on steroid and on hemodialysis, how do we manage the hyper and hypos associated with the management? What is the blood sugar range that we should maintain so as to prevent the hypos and hypers in our patient?
with regard to the use of steroid, contradicting naka-steroid din, hinihemodialysis. Tama? Diba? Tama ba? Diba pag
No, kasi common sa, Jamie, common sa mga severe
COVID.
cases nowadays, ang protocol nila sa COVID, nagbibigay ng steroids sa mga pulmo. And then, yung mga nephro, they do hemoperfusion na dialysis. Oo, hemoperfusion.
Para i-remove yung
Pinasasabay nila.
I-remove yung mga toxins, di ba?
Oo, di ba nadadala rin naman yung steroid pag hemodialysis mo, usually nag-hypo sila. Pag nag-dialysis.
I want to share kasi.
Ikaw marami kang case na COVID.
Oo, kasi marami akong COVID. 8 yung aking nakaka-share ko nga lang kanina. 8 yung aking severe ngayon. Na lahat sila naka-intubate and then naka-steroids. Nag-uumpisa sila ng once a day na Dexa eh. So, syempre, itong mga patients na to, di ba, pag severe, naka-intubate yan, and then naka-NGT ka rin naman. So, we normally, if you do insulinization, you also handle, pag nirefer sa atin yan, we handle feeding. So, pag nagda-dialysis for hemoperfusion, sa aking experience, hindi sila nag-hypo. Not like yung dialysis na ginagawa natin during normal times, no? Yung hindi COVID. Hindi talaga sila bumababa. Walang bumaba. But just the same, I checked the sugar before dialysis and then during, but I haven't seen much of hypoglycemia. It's really more of hyper. Talagang ang referral sa'yo, nag-uumpisa ka ngayon ng mga 600, 500. Kaya dadami yung pasyente mo eventually because hindi na nila ma-handle yung ganung level ng sugar because of the steroid. So, ako, I start PhilHealth nga, no? Isa pang challenge sa atin. PhilHealth doesn't allow the use of analogs, di ba? Sa amin, basta PhilHealth, which is most of our patients sa COVID, analog insulin are not allowed kasi it's not in the PNDF. Although there are hospitals which will allow you to give it, but you have to write a justification. Kaya ako, personally, natuto ulit akong gumamit ng mga human. Insulin. Tinatime ko siya kasi you have to consider yung nurse mo pabalik-balik dun sa pasyente. We want to minimize that. Ako right away, I start with a 70-30. Okay. Kunyari, I give 6 feedings in 24 hours. So 6, 10 to 6 yan ang time ng nurse, no? So I give my insulin naman 6 a.m. and 6 p.m. 70-30 at equal dose kasi distributed naman yung we don't meal. Follow the 2/3, 1/3 kasi distributed nga yung meal. So normally I start with 20-20 and then I give regular in between pre-feeding. Correction insulin. So, bihira ang nag-hypo dun sa mga kasong yan. Maybe because of the severity of the infection and then the steroids. Pag ganun na kalala, pag nag-worsen, they go up to higher doses of steroids. Ayan na, talagang hilong-hilo ka na sa mga referral mo ng blood sugar mo, 400, 500. So, ang mga boluses natin, mga 20, aakyat ka talaga ng mga 40-40 ng mga 70-30 mo. So, this is a really trying times for us in terms of diabetes management sa critical patients. So siguro we can have a session on that as well kasi medyo madugo pagdating sa ganyan, kuya.
Nung
si kuya magaling dyan.
Monitoring thing.
Ang kinausap nga ako ni Doktora Rima. Nandiyan ba si Doktora Rima? Nabigyan niya, dapat naka-libre na. Para mas madali at hindi na pa labas-labas ang pasyente. So unfortunately, nag-order ako, it's not yet here. So talagang naka-prick pa rin talaga ako ng Q4 Kasi lumalabas ang feeding mo Q4, di ba? Maganda sana kung naka-basal tayo ng isang mataas at nagbo-bolus tayo ng every 4 hours. Pero may ganon na ospital, pero karamihan ng ospital dito sa amin because COVID is very strict sa kanilang approval, any use of non-PNDF may disqualify claim. So, ayaw ng ospital yon. So, they want us to stick with the PNDF-approved medicine. So, balik tayo sa ating human na insulin.
Meron ako nabasang journal na ginawa naman sa, I think sa China yon. Sa labas ng pinto, meron silang mga tape na nakahangs pang hanger. Doon nasa labas ng pinto, doon nagtatitrate yung nurse. Para siya naka-insulin pump, doon siya nagtatitrate. So, wala siyang exposure sa patient. So, ang pasok na lang nila is yung pagmo-monitor. Pero, nakapump sila. Pero nasa labas. Maraming nakahang, maraming tape sa door. Kaya parang walang labas yung Pero parang hindi siya reasonable para gawin yun. Natin.
Maganda talaga kung yung nakalibre.
Basal ball.
Oo.
Drip.
Pati yung ating ang drip, magandang kasi hindi na namin ina-ICU yung aming pasyente. Kung saan siyang room, pag na-intubate, doon na sila. Kasi ayaw na ipagamit ng ospital doon. Kanya-kanya, wala nang lipat-lipat. Pero human, tama si Ate Leyden, human pa din po, Ma'am Leyden, ang ating insulin.
Okay.
Because of the PNDF requirement.
Okay.
Wala tayong
talagang this is the time that we all have to be creative. Yes. Huwag nyo kakalimutan this is the first time na nagkaroon ng pandemic. Kaya huwag kayong matatakot gawin yung tingin yung tama, Kasi may basis naman tayo, merong science at saka merong konting evidence na lumalabas unti-unti. Pero pag ginawa niyo yung tingin yung tama, para sa akin, that is a very, very big thing already. Very big thing. At the end, malalaman natin lahat yan Pagkatapos pa siguro ng isang taon.
Nakaka-nervyos pa rin, Kuya.
Kuya, another question.
Hindi mawawala yun.
Pumapasok ba ako? Another question, Kuya?
Yes.
Please comment on the claim. This is from Roman. Please comment on the claim of protective use of melatonin and virgin coconut oil against infection.
Parang topic yan, next meeting. Next series is the virgin coconut oil.
Yun ba? Ayun, yung virgin
we will
coconut
have
oil.
a lecture by Dr. Olive.
Isasama na niya yung melatonin doon,
Tanong to give or not to give.
Next is from Wewet, just a comment. Some patient may initially present with DKA without other symptoms of COVID. Always have a high index of suspicion. So sabi niya, marami daw nagpe-present ng DKA pero walang signs and symptoms. So we must be aware of it. You have to test it. From Wewet.
Point well taken.
Okay. From Dr. Leia Kailao, what characteristic of patient that can we predict the occurrence of cytokine storm?
Jimin, mahirap yan.
How do you predict?
Ito lang Dalawa yung sinabi nila. Classic, very safe answer. Number 1, age. Yung mga matatanda. Classic age. Pag matanda, mas madalas doon yung cytokine storm. Pero be aware that lately, pati sa bata, nangyayari na rin, Kaya hindi siya matanda, hindi na mangyayari yon. And number 2, the presence of comorbidities. Yung may diabetes, may hypertension, may obesity, may cancer. Yes, oo. Yan yung mga tinawag ng classical kasi yan yung unang napansin nila sa Wuhan yung comorbidities at saka yung age. Nevertheless, kailangan habang nag-e-evolve itong pandemic, maging maging vigilant tayo kasi nag-e-evolve din yung statistics Di ba, nasabi nga ni Webet, asymptomatic, pagkatapos DKA na pala, ha? See? Kaya, be always on the lookout.
Okay. Another
Share.
question. Ayan na. From Georgie Muli. Are there specific reasons that predisposes diabetic patients to severe and critical COVID infection? Diniscuss mo yan.
Oh. Di ba sabi natin, hindi diabetic ka, magkaka-COVID ka. Lahat tayo, regardless diabetic or not, can be infected by COVID-19. Only if your sugar at being diabetic are not controlled, yung prognosis mo worse. Not compared to maganda yung control, pero nag-positive siya sa COVID, ang chances ng recovery mas mabilis. Pwede pa ngang i-home quarantine kung mild lang.
Kuya, di ba may relation yan sa defenses? Pagka normal ang ating sugar, yung defense ng body natin, di ba meron yan?
You're right. Ang tanong niya yung susceptibility. Kung ang difference ng susceptibility ng may diabetes at walang diabetes. Ang susceptibility is defined by the presence or absence of the functional receptor. Ano ba pang functional receptor? Yung ACE2 receptor. Whether you have diabetes or not, meron ka ACE2 receptor. Lahat tayo may ACE2 receptor. Kaya lahat tayo susceptible. No? Do not forget that. No? Yung definition ng susceptibility, yung presence ng attachment niya ng viral particle. Ngayon, ang tanong, ang feeling ko, yung tinatanong niya, kung sinong mas magkakaroon ng severe. At nasagot ni Dr. Jamie yun. No? Pagka ang blood sugar mo well controlled, chances are your defenses are intact. But in persons who have high hemoglobin A1C, you can suspect, this is not proven, this is a theory, you can suspect that there is glycation of your immune complexes, there is glycation of pathways that are necessary for tackling the invading organisms. Therefore, this can also have an effect on the outcome of the infection. Pwedeng hindi lang maging infection, pwedeng maging disease at pwedeng maging severe. Yung exact mechanism kung bakit dumarating yung cytokine storm is still not very clear. Kaya alam lang natin pagka very uncontrolled ang blood sugar, hypertension, severe, mas madalas yan. Siguro maghintay pa tayo ng 1 buwan, 2 buwan siguro, unti-unti na may explain niya mga yan eh. Pero ganda yung bradykinin theory eh. Maganda yun. Kung aaralin lang natin lahat, siguro isang session yun eh.
Sir, I have also been heard from the last EASD that type 1 diabetes, yung mga bata, less ang chances nilang magkaroon ng COVID kasi mababa pa yung ACE2 receptor nila sa body nila. Not like yung matatanda, marami na yung kanyang ACE2 receptor. Kaya mas madali na siyang parang ginagamit na entry ng virus.
That is good, ano? That is a good, no? Good nasa article 'yan, ano? Na mas mababa yung yes. Pero yung isa sa mga articles na lumabas sa mga bata daw, no? Pag bata pa, yung non-specific defenses, yung intrinsic, yung innate at saka yung barriers na yan, very active sa mga bata. Kaya itong mga batang to, kahit anong klaseng infection actually, lalabanan yan non-specific eh. Yes. Pero habang tumatanda tayo, no, yung ating non-specific defense, no, unti-unting hindi naman 100%, ano, pero unti-unting napapalitan. Hindi tama yung term napapalitan, no? Pero humihina ng konti in favor of specific immunity. Kasi habang tumatanda tayo, na-expose tayo sa iba't ibang antigen. Na-expose tayo sa chickenpox, expose tayo sa mumps, na-expose tayo sa lahat. Dumadami ang ating specific defenses. Pero yung non-specific, medyo mababa ng konti. Kaya yung mas matanda, mas ngayon prone pagkaroon ng disease kaysa infection lang compared dun sa bata. Again, that is a theory. Kamukha ni theory, kinukwento ni Jamie. Kaya maganda yung alam natin yung mga ganyang theories. Siguro later on lalabas yung mga proofs kung alin sa talaga sa kanila ang nagpa-participate.
Okay. Another question from Ninita Tan. Kuya, how
Ate
long,
Ninita,
Ninita Tan,
Si Bobby.
how long will the last dose of steroids remain in our body to affect the blood sugar level?
gano'ng katagal nga ba?
Oo nga.
Totoo
Depende
lang?
yata kuya sa ano eh.
Minsan,
Depende yata. Kasi yung dexamethasone ang ginagamit nila, hindi yung hydrocortisone. Kaya yung dexamethasone, mas mahaba ang span
Half-life.
sa half-life kesa doon
Mm-mm.
sa hydrocortisone. Kasi kaya medyo mahaba usually sa observation ko doon sa mga dinedexa, if you'll talk about yung pagtaas pa ng sugar, tapos abruptly binaba nung diniscontinue nung pool mo, nakikita ko bababa yung sugar after 2 days.
so the effect of the drug, theoretically, pharmacologically, is about a day. About a day. Yun ang pharmacokinetics ng drug. However, the response of the body in terms of blood sugar response is undetermined. May mga individuals ako nakikita na kahit bigyan mo matas steroids, hindi sa blood sugar. Ang ganda ng kanilang response sa steroids. Yet, I see individuals na konting steroids lang. Makanti mo lang na konti ng steroids, 500, 600 ng blood sugar. So,
Meron
it
yan.
can be anywhere in a spectrum. What is important, as doctors who take care of these patients, we check the blood sugar regularly and respond to the response of the patient. Kung paano nag-respond yung patient doon sa steroids. So, pharmacologically, after 1 day, dapat, pagka nabigay pagka tinigil na yung steroids, dapat nawawala na yung effect. But continue to monitor your patients because our patients, not all of them read books. Hindi binabasa yung pharmacology. Hindi sumusunod eh. Kaya tama si Marcy, kung minsan dalawang araw na nakatigil, ang tataas pa rin ang blood sugar. So,
Meron nga.
you continue monitoring your patients, continue to responding to your patients, but at the back of your mind, you know what you are doing. Okay?
Agree.
Kuya, meron pang isa. Since skin serves as a barrier and act as a protectant, skin lesion may be a sign of COVID infection. Kay Dr. Ignacia Fajardo.
Thank you for that question. Nagle-lecture na yung mga dermatologists. yung mga cutaneous manifestations of COVID. Yeah. Kasi under the skin, meron ding ACE2 receptor. But that is not the primary mode of entry. That's not the primary. No? The primary is still the respiratory tract. No? The respiratory tract. Nandiyan ang karamihan ng cause of transmission. But he is correct. You can have skin manifestations. There are many kinds of manifestations that they showed eh. Sorry, hindi ko na memorize lahat eh. Pero ang dami skin manifestations na pwedeng dahil sa infection ng SARS-CoV-2. So that is possible. Sorry, I cannot answer the specifics of the specific answer I could not give you. But yes, you are correct. It is possible. You can have skin manifestations. Hindi ko lang alam kung paano nakapasok din yung SARS-CoV-2. Kasi dry ang skin, impenetrable yan. Pagka nagkaroon ng sugat, ayan, pwede siya makapasok. But that is not the primary mode. Ang primary mode pa rin is
Respiratory.
A comment.
Yes.
Okay, a comment naman from Toti Hipolito. Sabi niya, diabetes weaken the immune system once it's elevated, di ba? Yan na nga, kuya. Di ba? Tama naman yung sabi niya. Tapos kuya, may tanong ako sa nangyayari dun sa rheuma cases, di ba? Yung rheuma cases, nagkakamali yung ating immune response. Nagkakaroon tayo ng mga tinatawag na maling immune, mga complex na hindi dapat o maling signaling na nagkakaroon tayo ng sakit dahil doon sa sarili nating immune system na nagkamali.
Yes. That is a slightly different, interesting phenomenon. Yung mga case na nagkakaroon yung tinatawag na, tawag doon? Molecular mimicry. Molecular mimicry, no? Because of the presence of an abnormality in the chromosomes natin, no? Na-identify natin yung isang antigen, no? As something that is also present in one of our systems. Sa totoo lang, yan ang nangyayari sa type 1 din eh. Kaya
Type 1,
nako-compare
yes.
sa yung dalawa eh, no? Sa type 1 diabetes, no? Pag nagkaroon ng
Antigen.
specific kind of infection, no? Na trigger doon sa isang individual yung kanyang response against a certain antigen, yung antigen na yun pala eh, nandun din sa beta cell. No? Parang nagkakaroon ng molecular mimicry. Yung antigen is similar to the beta cell composition. Identified na nila yun, yung DAG protein yun eh.
Kayo.
Kaya pagdating ng immune cells, yung killer cells, pati yung beta cells napatay. At ganoon din yata sa nangyayari sa sa rheumatology, yung mga
Rheumatic heart disease.
rheumatic heart disease, nagkakaroon ng immune destruction of self. Yung na-misrecognize ng immune system, yung self because of abnormalities doon sa tawag dito sa MHC, human compatibility molecule siya eh. Ako, hindi ko pa na-aaral yan. Sorry pero you are correct. May kinalaman yung immune system sa pag-destroy ng self.
Okay.
Pero hindi yan ang nangyayari sa sa COVID. Hindi yan nangyayari sa COVID.
Wala na tayong further na kwentuhan next week. Kaya kung may tanong pa kayo, siguro we'll give you meron na lang a few minutes. Kung wala naman, we'll end up the session.
Kasi next, palagay ko next week, lahat na nag-cancel ngayon, next week magkikita-kita yan. Marami sa next week. Ang dami nag-cancel ngayon. Pati mga schools, lahat ng meetings
webinar ata kinancel nila rin.
Ayan. So probably we'll end up our discussion tonight. So we go back to our
Host.
Thank you sa sponsor
for tonight.
Thank you sa Gets.
Thank you, Gay.
Hello.
Back to Dr. Fatma.
Okay. Thank you, Mars. Thank you, everyone, for your active participation. So, in the interest of time, we cannot answer all your questions and there will be no session break tayo next week. Just keep writing us kahit dun sa chat group. Pwede natin ipagpatuloy yung ating usapan. And for tonight, we would like to just end this with a very happy and empowered heart na kayang-kaya na nating gamutin ng ating mga diabetic COVID patient. Maraming salamat sa ating speaker. Maraming salamat, Kuya and Dr. Jamin. And also, most especially, we want to thank our sponsors. Sila Sir Larry, yung ating matyagang nasa tech team natin na tumutulong sa atin from GET, si Miss Tam, si Miss Noemi, and of course, yung si Ma'am Rose Ann De Rosas, yung nag-present sa kanina sa kanilang insulin. Tulungan po natin sila, pasalamatan natin sila sa tulong din nila sa atin. So with that, we say goodbye everyone and enjoy your dinner with your family. Bye!
Bye!
Thank
you!
Are we going back to the old way? Bye-bye!
Bye, Sir Larry!
Thank you!
Thank you!
everyone!
Thank you, everyone!
Thank you!
See you!
Hindi lahat magkakaroon
Ganda-ganda ng MTV natin, no? Sa susunod, mabubuo na natin.
Hindi pumasok
Mula sa series 1.
hindi siya makakapag...
Dugtong-dugtongin na natin. Meron na tayong
Ay.
isang pelikula.
Hindi natin na-mention na ang susunod na series is October 3.
Hindi next week yung 3 eh.
O nga,
October-
nakalimutan